Vascular access simply means the route of access that we use to insert the tube that we need to use in order to perform the procedure. So we have to access an artery. We usually use a tube which is 2 millimeters in diameter, and when we use tubes which is at the smaller end of the spectrum, for that we can use either an artery in the wrist that we call the radial artery, or we use an artery in the groin which we call the femoral artery. And we usually use we prefer to use the right hand side, and the simple reason for that is that the way the patient lays on the table, their right arm and their right leg are closest or nearest to the operator, so it's just ease of access. But if we have to, we can use the left hand side if for whatever reason access from the right side isn't possible. There are, if we're doing more complex work and we need to use slightly bigger tubes, then it's much safer to insert those via the femoral arteries, because of the fact that the radial artery is of course much smaller than the artery that provides blood to the legs. And very rarely we may have to put in, or very occasionally may have to use other access, in the sense that certainly if we're doing rotablation to the right coronary artery, there's a chance that the patient's heart rate may slow down. So we may put a tube into the vein at the top of the leg so that we can put a small wire inside the heart which is able to pace the heart if the patient's heart rate does slow down. There is another a technique which is really more historical now, if patients don't have either radial or femoral access, where we can actually do a direct cut down onto the artery at the elbow. But that's done very, very rarely indeed, and we call that brachial arterial access. But if most patients will have either radial or femoral, and it's often a choice. Most operators now are preferring to go radially because the patients generally find that more comfortable. I find in men that's okay. In women who tend to have smaller arteries, actually they often get quite a lot of spasm, which can be quite uncomfortable. And so I often find that my female patients actually prefer to have a femoral approach.